us on the panel. Of course, we've already met Drs. Wirth and Dr. Young, and we have Dr. Tony Caggiano from Acorda Therapeutics. Acorda has been a very strong supporter of Working2Walk since the beginning, 2006. They've been with us and sponsoring every year, so we're really very grateful to them for that past support, and I'm sure that will continue because they're a really great group. And we're very happy to have Dr. Caggiano here. He is the medical director for preclinical studies for Acorda, and I know that most of us are aware of the famotidine 4AP product that they developed and is now in use for patients with MS. And I think a number of people here for spinal cord injuries have at least had an opportunity to maybe try it or think about it in addition to what the studies for the MS patients. So we're really happy about the work that they're doing at Acorda for neuro injuries and conditions as well. And we also have from the Norwegian Spinal Cord Injury Society, the president of that society. And I know I'm going to slaughter the last name, so it's Leif Veldheim. Close enough. Although I told him I'm actually from Minnesota. Norwegian #1, he said. I'm actually from Minnesota, and have relatives from Norway. So Leif informed me I could come hang out with them later on if I wanted to. I'm in the Norwegian club. But I've actually met Leif online several years ago on CareCare, and we've corresponded frequently since then. So it's always really exciting to meet somebody that you've been talking with and have gotten to know online over the years. So really excited that Leif and his group are here to join us. And we had a global partnership meeting with all of the international attendees last night, and it was really, really fascinating to hear about all the things that they're doing all over the world and some of the struggles that they're having and successes that they're having. And Norway was really ahead of the game and really a leader in advocacy for spinal cord injury, and we have a lot to learn from them. So we had a great meeting last night and learned a lot from everybody from the international community. So we thank them for that and taking the time out to do that last night. So with that, we'll just do a question and answer period with our panelists, and looking forward to that. Thank you for being here, everybody. So we have any questions? I think, Leif, you were going to.
Yeah. This question is for Wise. Wise, I'm curious about the clinical trials in Austin. It wasn't clear to me from the presentation. Are you doing human clinical trials there yet? Where does that stand?
Yes. Unfortunately, I had to cut the clinical trial part of my talk short. I spent too much time on the 101. We proposed 5 trials in China, and we have completed 3 of the trials. We're doing the 4th, and we soon will do the 5th. So our current trial right now is transplanting umbilical cord blood mononuclear cells into the spinal cords of people with spinal cord injury, and we're increasing the dose at each sequential step. We're starting out with 4 microliters, then 8 microliters, and then 16 microliter injections. And then we're going to go on to 16 microliters plus a bolus dose of methylprednisolone, and then that treatment plus a 6-week course of lithium. And so this is what is called a phase 1/2 escalating dosing trial. I was so happy when Ed Wirth told me a couple of months ago that the Geron trial has actually leapfrogged us, and they're putting in 25 microliters into the spinal cord, and apparently the FDA in the US has accepted this. We're still proceeding cautiously. We are doing increasing dosing. Our first patient was scheduled for October 11, but unfortunately we had a glitch in terms of our GMP protocols, and we wanted to carry out all our clinical trials in complete compliance with US FDA standards. And so we had to slow down our process and revamp our process so that we got a consultant to come in and just examine every one of our steps. So he recommended a couple of steps. So we have been working very hard over the last 6 weeks, and so we hopefully will get word that we're in complete FDA compliance. And then our first case, if we get the signal to go, our first case is on November 29th. It's been scheduled, and everybody's very excited. Everybody's ready to go. And as soon as we do the first case, we'll probably do 2 to 4 cases per week, straight through. We have obtained all the permissions in China to actually do a parallel phase 1-2 trial in Kunming in China. And then as soon as we get the safety data for that, we will put that safety data into an IND, which is an application to the FDA for a clinical trial. And we're going to try to get a phase 2 trial started in Austin, Texas, in Brackenridge Hospital. And hopefully we can do that maybe in April of this coming year. As soon as we finish that trial in the US, towards the fourth quarter, the end of 2011, what we want to do is to initiate simultaneously 3 phase 1 trials around the world. Maybe 4 in Norway. We've been talking. But this means China, US, India, and Norway. A lot, I believe in setting ambitious goals and trying to hit them. And these are very ambitious goals. And we'll do our very, very best to get there.
Thank you for having this fantastic conference. It's great to be here and great to see so many wheelers. But as a patient or a user of this research, I also would like to ask a couple of questions. I just thought about 2 things when I saw your presentations, by the way, which was excellent. And as you know, Norway as well then want to participate and do something, and especially for chronic spinal cord injuries, because we are too few to start maybe for acute therapies, but chronic would be excellent. And we have good facilities and excellent researchers and clinicians. And in Norway now we have a consensus. We have already made a working group. We actually, last year we met Wise Young, me and a doctor from Sunnaas Rehabilitation Hospital, which is the biggest hospital for rehabilitation of spinal cord injured people in Norway. We met Wise 1 year ago at the ISCOS conference in Florence and invited him to Norway. So that's a year ago. And in Norway now then we have this working group, and our organization are in, and we have the 3 spinal cord injury units are in. And we have the research community with the basic research group at the University of Oslo and the National Stem Cell Center are in. But still, this is almost a year now since we decided that we wanted to do something, and the willingness are there, and everything, everybody is quite positive. So this is a question then to Wise. What will the advice be, not only for Norway, but other countries, since we have people from Ireland, UK, Spain, and so on? What could be a good advice to speed up these processes? The willingness are there, but even in Norway, with all this great attitude and willingness, 1 year has, it's out of the window almost. So the time is flying. That's my question, if there are some advices there. And then I have to speed up things then. And then I have also a question for Edward, and that is also, I saw your cells here. They can fix different things in sheeting, the axons, and also create neurotrophic factors, which could be great for chronic spinal cord injuries. So I'm also, since we are looking at chronic spinal cord maybe in Norway, what do you think, aside of the scar issue, if the scar issue was not a big issue, how good actually are those neurotrophic factors from the derived cells, from embryonic stem cells, compared to neurotrophic factors, say, from other types of stem cells? Thanks.
Do you want to answer yours first?
Of course, you can go first. I can go in order.
Yes, Leif. I feel every night every morning I wake up and I'm saying, "Oh, Norway, Norway." It's true, and what you're doing is the right thing. You put put as much pressure as you can on me and on others to get these things going. I desperately would like to get these trials going, and we're now. Let me first start by commenting on China's Spinal Cord Injury Network. We started this with essentially nothing, just the goodwill of the doctors who want to do something for the patients. And the doctors have spent literally many, many thousands of hours. We were holding 2-3 workshops a year. They trained. And in fact, I was commenting to some friends recently that even if everything were to stop right now in China, we would have done an incredible thing in China, because what we have now done in China is we have standardized all of spinal cord injury examination in China. This is the first time ever. So people can compare, and we've standardized. We've also established standards of care in China, and we have brought all the spinal cord injury centers in China to buy into the concept of working together to do clinical trials. Everybody said this was impossible to start with. So now what we must do in China is we must actually break through all the regulatory barriers so that we can get the trials going. And in China, the regulatory barriers, if you can imagine this, is worse than it is in the United States. In the US, they have strict barriers, but at least they tell you they have to answer you within 3 months, and they also have to give you a reason why. In China, you can apply, and they don't have to answer you for 3 years. And in many ways, we're breaking new grounds in China. Nobody has ever done clinical trial networks in China before, in the history of China. And so we're trying. At the same time, we want to hit the highest standards possible. Now, when we started China SCI Net, and then I then, because in the US they wanted to do network in the US, I am now traveling 350,000 miles per year. I received an award I did not want to get 2 years ago. I got the Million Mile Continental Award. I'm going to China now twice a month, or India, or somewhere. And so one of the things that I would love to do, and what is necessary also in Norway, is that in every one of these networks, we must have somebody local who can drive the network. It cannot be done by me overseas. And so in China, we have a woman, her name is Wendy Cheng. She's, the rallying cry in India was very interesting. They said, we have to find our Wendy in India, because they know that if you have somebody who can run the trial network, it will work. So you need that. You're right now our Wendy in India. I mean, Wendy in Norway. At some point, you need to have somebody, and you need to get the network. And as you know, the fundraising takes time. And then finally, we've got to get the training of the people together. And I hope that sometime in January, I can come back to Norway, and then we can talk. Not just talk, but actually set some milestones and goals. What you're doing is the right thing. Come to every one of these meetings, put pressure on me, put pressure on Ed, put pressure on Tony. I mean, we are, put pressure on us, and just make sure we never forget, and make sure that we wake up every morning and we say, Norway, Norway. And this is how you get these things going. Here, your turn.
No, thanks, Wise. Just to echo some of what Wise said, Leif, it's all about, money, time and money and people power. So, just to kind of give you an insight to Jaron, for example, so my clinical team that's been doing all of the work for getting approvals from the IRBs and doing budgets and contracts and training the sites and the surgeons and what have you, we only have 3 people on my team, including myself. So it's a mountain of work. Our preclinical team that does all of the injuries and transplants in the rats and mice is also consists of only 3 people. So we obviously rely very heavily on outside, entities to help with that. But it's an enormous amount of effort. And when I went to our CFO this summer and said we're getting the trial underway, I need a clinical assistant to help with the mountain of paperwork that's accumulating. He said, "No way, find somebody in the company who can help you," and we did. So anyway, that's just to speak to what Wise is saying. I mean, about how long things take. I mean, it really is an enormous amount of effort. It's a 365-day-a-year job, literally. So back to your question about chronic spinal cord injury with the OPCs. Our working hypothesis is that the scar tissue that forms is really the biggest barrier to OPCs having any benefit in chronic spinal cord injury. We attempted a pilot study with Hans to test that hypothesis. Unfortunately, the approach they were looking at was to actually genetically modify the OPCs to express chondroitinase to break up the scar tissue, sort of a do-it-all in one cell kind of approach, and they had problems getting that genetic modification to work. I think there are other strategies that probably are more promising. So, for example, with chondroitinase or with Decarin, which Stephen Davies is going to talk about, it may be that you need some type of co-treatment or maybe slight pre-treatment where you go into a chronic injury and you administer something to at least temporarily break up the scar tissue and then inject cells, be the OPCs or maybe even cord blood cells ultimately. So, it's very clear this is a complex puzzle that's going to require a bunch of different pieces, and I think figuring out how they all fit either sequentially or which pieces need to be done together is going to be one of the challenges. And again, every combination and permutation of figuring out how those pieces work takes another, big chunk of effort. So that's definitely something we're interested in. We routinely try to reach out to academic labs to collaborate with them on issues like this. We would love to collaborate with someone like Stephen Davies' lab, for example, to see if, in fact, combining Decarin and OPCs in a chronic injury model might have some benefit. Yeah.
Great.
With that.
I think we have a question back here. Did you still have a question?
Sure can I. This is a question is for Ed. For the clinical trial, two questions. One part is, do you do any physiology monitoring of the patient when you inject the cells? I realize it's a complete injury, but I'm wondering if you do any physiology. And the second question is, especially considering your background in imaging and imaging of cells and so forth, is there a plan in the future to add agents in which you'll be able to track the cells and image them in vivo?
Yeah, but both good questions, Phil. So for those who don't know, Phil Horner was just asked the questions, one of the speakers this afternoon. With regard to the intraoperative physiological monitoring, so when people have spinal cord surgery for any kind of reason, be it a tumor or some other reason, they generally will attach electrodes to the head and to the legs, and they'll monitor conduction of nerve impulses from the brain down to the legs. That's called motor-evoked potentials. And they'll also monitor conduction of impulses from the legs up to the brain, called sensory-evoked potentials. And these are very, very important for safety. Unfortunately, when you have individuals who have a very, very severe spinal cord injury, such as the individuals who are being enrolled in the first cohort in the Geron trial, these impulses that are recorded by these evoked potentials are completely absent. So, Phil, to your question, then directly, no, we're not doing intraoperative evoked potential monitoring in this cohort at this time. That being said, it's definitely something we want to look at down the road, also because it's a way potentially to look at the return of impulses and see if they return to a greater degree in individuals who are getting cells than you might otherwise be expected by as a course of the natural recovery. To that point, the European Multicenter Spinal Cord Injury Group published a very, very interesting paper. Armin Kurt, C-U-R-T, was their lead author. And he showed that, in fact, that in the majority of folks who have a neurologically complete spinal cord injury and show recovery, there's no change in the evoked potentials. So very, very interesting. How is this happening? And they hypothesized that this is due to rehabilitation and adaptation based on what you have left. So, it's very enticing to think, well, if we can do something to maybe then improve those conduction of those nerve impulses, maybe that then provides an added kick for rehabilitation to then really take things from there. So that's your first question, Phil. And then with regard to tracking the cells, it's also a very, very good question. One of the things that's very important is how do you track these cells once you've injected them? And you need some type of either a label that's put into the cells, or generally what another approach people take is to genetically modify the cells to express some type of chemical that then can be followed with some type of imaging technology, whether it's magnetic resonance imaging, MRI, or some type of other imaging technology like optical imaging. Phil, we don't have, unfortunately, a label like that yet for our OPCs. We have, in some of the non-clinical studies, genetically modified the embryonic stem cells to express a protein called green fluorescent protein, which could then be looked at in tissue sections. But unfortunately, changing our product now to add a label in, for example, literally would require redoing a whole bunch of the very, very big non-clinical safety studies. So it's a big undertaking. Unfortunately, you have to go back. So it isn't something that we have the capacity to do right now, Phil, but it's a great question. See the question in the back? It looks like, oh.
Right here?
Oh, there you go.
Wise, earlier you mentioned how crucial it was to actually know where the cells are coming from and who's manufacturing them. I was wondering if anyone on the board could enlighten us a little bit about the Excel company over in Germany that I think just recently had a fatality.
Does anybody want to comment? I know only from internet, but a young child died because they injected the XL bone marrow autologous cells into the brainstem, and this child had a hematoma develop, and they didn't recognize it early enough, and the child died. The surgeon who was doing it was employed by XLs and was in Dusseldorf, but at the time this happened, she quit from the company, and so there's nobody to sue. So the parents are suing the XL itself. XL, as you know, is a company that has been set up by Kleinbosum, who had done this for many years in Turkey, in all these different stands in Russia, and so on and forth, and finally moved to Cologne, Germany, where he set up this thing where he's taking advantage of a loophole in the German law that allows autologous cells to be given to patients without having any regulatory approval. And then they find some doctor to infuse this intravenously or intrathecally, and in this particular case, a doctor who decided to inject the cells directly into the brain and didn't monitor the patient afterwards, and the patient died. There's very little science behind this, and I have been discouraging patients from going.
Does anybody else up there have a comment? I think we have time for one more question, but I just want to make sure everybody knows that these gentlemen will be here for the remainder of the day, and they're available to take your questions outside of the session. So please, if you have questions that we didn't have time to get to now, don't feel like you have to forever hold your peace. They'll be here, and they're, I'm sure, looking forward to speaking with all of you. So one last question.
This is for both the doctors, Dr. Young, Dr. Wirth. What is your criteria for acute versus chronic, and will there be a study in the near future on chronic compared to acute with either one of yours?
So there aren't very, very clear distinctions between acute and chronic and this period in between that we often call subacute, actually. Generally, drugs or other therapies that have targeted acute spinal cord injury for acute neuroprotection, if you will, such as prednisolone, for example, need to be administered very, very quickly, generally within the first 24 hours and often even earlier than that. With methylprednisolone, it seems to be ideal if given within the first 2 hours. The period from about roughly 1 week after spinal cord injury out to about 1 month in rodents is generally the subacute period, where the majority of the early things that happen after spinal cord injury, what we call the secondary damage, has basically now resolved. And then you start entering a phase where really it's just formation of scar tissue from that point forward, and much more of a static type injury, although there certainly are obviously things that can occur very, very long periods of time afterwards, such as neuroplasticity and axonal sprouting. So that's roughly the time period. So Geron, again, because we haven't seen benefit yet with the OPCs in a chronic spinal cord injury, and by that I mean in the rats greater than 2 months out. We really don't know at 1 month, but from 2 months out we haven't seen it. That's the rationale for injecting the cells in this first clinical trial at 7 to 14 days. And I'm going to hand the microphone off to Wise, because they are in fact starting in folks with chronic spinal cord injury with the mononuclear cord blood cells. So Wise?
Our definition is more than 1 year after injury and at least 6 months of stable neurological function. And I'll answer the next question, which everybody always asks, is how long after injury matter? And basically, we're not making a distinction. We are setting a time limit, and that time limit is going to be from 18 years to 64 years of age. And we will take patients as long as 40 or 50 years after injury. And we're truly addressing chronic spinal cord injury.
Yeah, I have one question maybe to Accorda Therapeutics as well into all this. Where do you see your product could fit in with all these combination therapies since combination therapies has been discussed? And can you say a little bit about Accorda Therapeutics, what you are providing as well? Thanks.
So Accorda was founded with the mission to develop therapeutics for spinal cord injury, and since have evolved into spinal cord injury and MS and other related disorders of the central nervous system. We started working with 4-aminopyridine in spinal cord injury and had some pretty large-scale failures or neutral studies in spinal cord injury. Now fampridine, now known as dalfampridine or Impura, is approved to improve walking in people with MS. So it's really not appropriate for me to comment on its potential use in spinal cord injury. But our earlier pipeline, we have at least 3 things that we're interested in using in spinal cord injury. One is chondroitinase, which obviously has had a lot of attention. Another is a growth factor that we use in a variety of traumatic disruptions of the CNS and shows promise. And then a third is a family of antibodies which promotes neurite outgrowth and hopefully plasticity and may also have potential in spinal cord injury. So we're still very interested and devote a lot of time and money in animal studies for these compounds.
Great. Thank you all again for answering these questions right now. And again, if you have questions remaining, feel free to approach everybody on stage. And there will be breakouts later as well where you'll have interaction directly with them. But thank you, gentlemen, very much.
Visit u2fp.org for more coverage from Working2Walk and the latest in spinal cord injury news.